Thank you very much for having me. Great to be here. I've long admired the programme that goes on here, and really interesting to come and meet you all. So yes, I always found it best to write your own job description. I managed to do that for the last 3 or 4 jobs I've had, which is a strategy that's worked to date, although I'm about to be moved into NHS improvement, so I'm just keeping my fingers crossed that that's going to kind of work out all right. So I was a GP in the east of England for quite a while. My first job after qualifying was in Abbots Langley in Hertfordshire, an idyllic little village, actually a suburb of Watford, and the east of England's only Premiership football team, by the way. Just saying. After that, I got involved in education, training and development in the early 1990s and have worked in that area ever since. Did a spell working as a GP in London, in Burnt Oak, in Stanmore, and was postgraduate dean for North Central and East London, and worked with Bill on some tricky issues about you've got more than I've got, we want some of those, that kind of thing. For the last few years I've been working across into the Leadership Academy, which is a national organisation now, built up of a national team that runs a suite of core programmes and 10 local, well, I was going to say outposts, but that sounds a bit kind of, it implies some kind of hierarchy. They were, of course, there long before the national organisation was invented by Lansley, one of his better creations. So that's me, and what I'd like to do today is not talk at you for very long, but I would really like your input into something. So it's a real opportunity to get involved in some national work that I want to describe to you in a second. But I'm really keen to hear from you. But I want to riff for a few minutes on the subject of leadership development for primary care, because that's one of the things I lead on for the Academy. The other thing I lead on is clinical leadership. How do we get more clinicians engaged in leadership activities of clinicians of all types, right from the undergraduate years through to sparking across that gap from professional leadership into corporate executive leadership. So that's that whole kind of pathway. It's an interesting fact, I think, that only 9% of our acute providers in this country have a medical background, for instance. Only 30% of them have any clinical background, which is unusual internationally, and would be very unusual, for instance, if you were running a school, to have somebody managing without any teaching experience. So that's another kind of hobby horse. So I think it's a really, really exciting time to be working in primary care. It's also a very, very difficult time to be working in primary care, but there's a huge amount of stuff that is going on and about to happen, and in progress. So you don't need me to tell you, but I will anyway, that but is it 90% of patient contacts take place in the primary care setting? If you take GP alone, it's about 300 million consultations a year. It's absolutely vast, the sector. But there are some kind of unique challenges when it comes to leadership and leadership development. So the scale and the depth of the change that needs to happen is probably greater than anywhere else in the NHS. It's also happening at a time of acute kind of pressure on service delivery. So you've got that sort of double whammy. But we've got a huge amount of stuff that needs to happen. New clinical models, new patient pathways, broader workforce, greater use of technology, working with patients on self-care, all of these whilst trying to maintain some of the core values of primary care at its heart. Second kind of unique thing, I think, is the that primary care is expected to work increasingly across organisational boundaries, collaborate, share resources, merge, and this involves a whole range of influencing processes that actually have been perhaps we haven't been trained in or know how to do. So, but this will become the norm in primary care. And thirdly, the other thing that for me is crucial is that we also focus on leadership from primary care rather than just in primary care. So how do we take some of the expertise and some of the kind of amazing people from the primary care setting and have them leading across wider healthcare systems? Why does it always have to be the trust chief executive that chairs the integrated care system? Or, you know, we're starting to see that changing, but it's the exception that rather than the rule. But there are a number of contextual factors that get in the way. There's been very little investment in building leadership and management skills in primary care. Most people haven't had any kind of formal training or development or support. We've got a range of interesting organisational structures and contractual relationships which can get in the way. And it's very hard to locate learning and development support and organisational development. Where do we go for that? Where's that access from? There's often the lack of any kind of progression system. So how do you work your way up rather than going from being the practice nurse one week and then leading on diabetes for the CCG the next? And we have been very bad at actually installing these kind of rungs of the ladder. Leadership itself is a rather is a word that doesn't go down very well actually for lots of colleagues. It's considered something that we don't do around here. We've got a different way of working. It's much more collaborative and all the rest of it actually. But that means then we kind of shy away from talking about it and really thinking about it and how we might do it better. So just, I think, get over it, I think probably is the message for that one. Appraisal systems don't really kind of sort of talk about the leadership management particularly well. We've got GPs dominating in a rapidly diversifying workforce. And if we're really going to make headway, we've got to broaden out the idea about you know, who leads and where we get that from. Funding is hard to find. Backfill's difficult. Who does the job when we're away being developed? Time pressures are really acute, and actually, people don't want to travel a long way away, and they don't want to do academic programs. They want just-in-time, pragmatic stuff that helps them sort out the day-to-day, the problems of the day-to-day, and that's generally not readily available. So what kind of leadership do we need in future? Well, if we're thinking about the overall purpose being about improving the health and well-being of local populations, we've got to shift from individual leadership to collective leadership, working across geographical areas. We've got to shift from leading teams and organisations to leading systems and networks, which requires a whole new set of skills. And we've got to shift the focus from managing today's business, something which dentists are very good at, particularly, I think, to designing the services of the future and leading change. So there's some big shifts we need to bring about, and we need a whole load of support then that will help us do that. A range of leadership development methodologies, different platforms, a coverage of a whole range of responsibilities and ways of working, accessible offers that are provided at the right time in the right place, and opportunities for new and emerging leaders to access the relevant development and support and be given the challenge opportunities they need in order to develop as leaders. So it's a big task and something we're not doing particularly well at the moment and something I'd like your help with. So, as I said, one of the things I lead on is leadership development for primary care. There's a lot of stuff that's happening at the moment, and I just wanted to kind of flag up a few bits and pieces. And it's been a busy couple of months across the system, and I don't know about you, but I've had lots and lots of reports, reviews, recommendations, plans appearing in my inbox, and I just wanted to highlight a few of them because I think they are immensely relevant. And the big one, of course, is the NHS long-term plan. I don't know, has anybody read the 143 pages of the NHS long-term plan? Has everybody at least opened the attachment? Because there are some really aspirational and really important things in here. Comes with a health warning, of course, because the 20.5 billion that's been promised by Theresa over the next 5 years some argue, may only just kind of get us back into kind of balance. So to what extent will we have enough left over to do what we hope we might be able to do? But and if you're interested, there's quite a nice Health Foundation kind of analysis of that. But if we're able to achieve some of these things, there's some really quite important stuff here. And I just wanted to kind of break this down for those of you that haven't managed to kind of plough your way through it, just because I think there are some really important things. And I've broken it down to three. The plan talks about some particular strategies, it talks about some particular structures, and it talks about some service improvements broadly. The strategies that it talks about, and this is a 10-year plan, so these are long-term aspirations. As Tony said this morning, there's a kind of interim stage for the first year because we don't quite know what the comprehensive spending review is going to bring later in the year, and the 20 billion was only funding for NHS England. It doesn't include Public Health England or HEE or a number of other elements. So the strategies are a bigger focus on prevention and population health. The 5-year forward view talked about that, but actually I don't think we made significant headway particularly. It talks about reduction of inequalities in a way that we haven't really sort of talked about since the Marmot review a few years ago. Integrated care at all sorts of levels, much more responsive emergency and urgent care. That gap that my father-in-law falls into between hospital and home on a recurrent basis with his 6 long-term conditions. Digital solutions, we've had a little about that this morning. Personalised care, which I'll come back to. A lot on workforce development and some stuff on research and innovation. The structures are interesting. Integrated care systems everywhere by April 2021. Moving to integrated care providers thereafter. So really trying to break down this commissioning provider split in a way that we haven't seen since I started, actually, when we used to have district health authorities. I don't know whether anybody remembers those, but place-based organisations that were responsible for funding care across the board. We do go around in circles quite regularly. Primary care networks, 1,200 of those across the country, approximately. I think for me that's an even greater shift. I think that could, if we manage to bring that off, that's profoundly going to change the way we work. And the third organisation structure is actually the individual. So we experiment with, we collect money in taxation and we deliver care over here. In between, somebody decides where that money gets spent, and we've experimented by giving it to various people along the way. So commissioners, strategic commissioners, CCGs, GPs. I was a GP fund holder for a while, that was nice. Got a nice new surgery out of that. and now we're trying to give it to individuals. So going up to what, 200,000, I think, personalised budgets, I think, in the not too distant future. And then there's a whole series of service improvements, which was the third kind of theme: cancer, mental health, cardiovascular, stroke, and so on, which largely continues some of the work that's been going on at the moment. So there's some profound change in there, and I think there's a huge number of implications for how we work in primary care. Then, as soon as that came out, about a week later, the Universal Personalised Care kind of framework. Has anybody read this? No. It's a really, I think it's a really interesting project. It's been in about 3 years in the making. So this is what has led to the 1,000 community link workers across the country that are going to be recruited to support social prescribing. This is where we find the stuff about the 200,000 people with personal health budgets, commissioning and buying their own kind of services. This is where we find a whole raft of initiatives around improving the way we hold shared decision-making conversations with patients, and there'll be a huge amount of training and development in that respect, and a number of other things. So well worth a read, I think. A lot of money will be flowing through this particular plan. This is all happening in January and February this year. So then there's the partnership review. Any GPs in the room seen that? I thought it was hugely disappointing, actually. This was a review of the partnership model. What are the alternatives? Does it work? Doesn't it work? The end result, sort of, it pulled its punches, made some pragmatic recommendations about a few things, most of which was going on already, and I don't think really answered the exam question, was actually, is the partnership model fit for purpose in any great way. Then we had a framework for GP contract reform. Here we find that we're going to get 1.8 billion flowing through to a network contract. So getting practices together with local providers, dentists, pharmacists, community nursing and so on, and some money coming through to the GP contract for services provided by networks. So that's going to be the microphone around which all of those organisations will cluster. A lot of that will be going on diversifying the workforce, so 70% reimbursement for a variety of new roles, physiotherapists, clinical pharmacists, physicians associates, and the social prescribing link workers mentioned earlier, and accountable clinical directors at the helm of some of those networks. So probably around about 12,000 of them across the country, each servicing a population of around about 50,000. And in fact, if we can bring that off, that's working at scale in that way. That's a profound change. But where's the leadership for that? What experience do we have at working in that way? How do we bring those disparate, contractual frameworks together and organisations? And I'm just going to flick through the rest of these. I put Kerr and Kerr review. There's a Kerr review and there's a CARC review, both reports to the Secretary of State from Sir Ron Kerr, and I can't remember his name, but a QC called Tony CARC, I think. The CARC recommendations is about having basically suggestions that we might professionalise the role of directors in the health service and start holding a register of them in their career history, so we don't just recycle people that fail. And the Kerr review, which is about how do we enable people that lead? How do you make it less burdensome on their time? How do we align regulation? How do we support them in doing that? So some pragmatic recommendations. We've got a workforce, the racial equality standard and the new disability equality standard published in January. This is all in the last 2 months. We've got the TOPOL review, which was mentioned earlier, worth a read. Big, thick document about how do we deliver the digital future. Then HE had a go, another HE report on NHS staff and learners' mental well-being. Less reports to read would have been a start, and more restructuring. So NHS England and NHS Improvement coming together. NHS Improvement decapitated last week. Everybody's now working to Simon Stevens, but we can't merge organisations because legislation won't allow, and we can't change the legislation because we're leaving the EU, or are we? Or we might be leaving the EU at some point in the future, maybe. Anyway, it takes up lots of parliamentary time, so a lot of stuff happening there. And then on top of it all, the Secretary of State has asked for a workforce implementation plan. Could you knock one of these up in 6 weeks for the NHS, please, as the instruction? And that's what I would like your help with, if that's all right. I'll come back to that in a second. It's got to be done by the 18th of March, so and get your input this afternoon. That would be greatly received, because I've got a call at 3 o'clock. I'd like to feed some of that into you. So, what else is in the air for primary care? Do you recognise some of these things? What other kind of initiatives, strategic directions are there? What else might be relevant to your work? Go and find somebody else that you're not sitting next to at the moment, and just quick 2 or 3 minutes on that question. Just pausing a second, I mentioned the workforce implementation plan and what I need your help with. So this is being chaired by Baroness Dido (brackets Talk Harding), who chairs NHS Improvement. It's got 5 kind of working groups. Something about the medical dental workforce, which Steve Powers, the medical director, is chairing. Chief Nurse Ruth May's chairing the future clinical workforce (brackets non-medical). Making the NHS the best place to work. Navina Evans from Elft. Leadership Development, Talent Management and Culture, chaired by Peter Homer, who chairs the Leadership Academy, and Technology, Skills and Enablement, which David Behan's chairing from HEE. Interestingly, this isn't an HEE thing. It's a let's all work together on this because it's a really big problem and a number of cross-cutting things. So this is the group I'm kind of involved in, Leadership Development, Talent Management and Culture. So this is a little diversion. That's what I'd like help with. My favourite leadership model, sorry, this is a sort of little appendix, is this. And it's in this little book called Leading in a Culture of Change by Michael Fullan, who's a Canadian who works a lot with the schools. And he says, it's actually quite hard to predict the outcome of your activities because life's complex. But basically, if you do these things, more good things will happen, fewer bad things will happen. Because if you do these things, you'll get commitment from people that are around you. And the things that he talks about are leading with moral purpose, understanding change, building relationships, creating and sharing knowledge, and coherence making. So one of the jobs of leadership is to make sense of what's going on for people. And you do that with hope, energy, and enthusiasm. Napoleon used to say a leader is a dealer in hope. So hope, energy, enthusiasm. A lot of that this morning, I thought. So it's this coherence-making aspect I'd like from you leaders in the room. And it's really to say, well, okay, well, what does all this mean for leadership and leadership development in primary care? And what key issues or actions would you like to see in the leadership section of the workforce implementation plan that I can take back, because I don't think we've got the primary care voice loud enough within that yet. And it'd be great if we can get some contributions from yourselves, because it gets me off the hook, and I'm sure you've got better ideas than I have. So I'll tell you what, I'll give you 7 minutes, okay, and then we'll quickly take some feedback. I've bust your tea break, but you've only had lunch, frankly. But it'd be really useful to get. So what, given all of that context, what does that mean for primary care and leadership development? What should we be doing in the academy and across what is beautifully termed the people function of NHS improvement? It's always good to work in a people function. So could the two of you who've been talking go and find another two, and maybe think of kind of three crisp, clear things that I can take away with me? Be really appreciated. Yes, I love drums. So what's the answer? What does that add up to? What do you think we need to do, all right, into our sort of 10-year kind of workforce strategy in relation to primary care and leadership development, talent management and culture? Who wants to go first? This group.
Yeah, we'd like to change the language. We want to rebrand GPs. We're nurses.
Okay.
And
Yeah.
we just think, you were saying that even the 111 advert says call your GP
Sure.
rather than call your practice.
Yeah. Okay.
And we think there's a lot that the multidisciplinary team can
Yes.
do, but the patients still culturally feel that they need to see a GP. And you were saying even about nurses.
Sure.
One of the nurses apparently said to a patient, "You're seeing me because I'm cheaper than the GP. We're saving money."
Right. Okay. Sure.
Yeah,
okay. Yeah. And that's maybe historically because we haven't had a particularly diverse workforce. The ratio of other practitioners to GPs in general practice always felt bizarre to me. It's compared to a hospital where it's completely the other way around. And Peppa Pig didn't help, frankly.
No.
Okay. So okay. So that's fine. Anything else? Anything?
On the
Language?
in the same way the politicians are talking about schools and hospitals,
Yes.
and you hear it over.
Yes.
and
You're
over
right. You're right.
So we say
Yeah.
on
Sure.
the table, but that's the language.
Yes, so in a similar way, I constantly have to keep reminding colleagues, actually, it's not all about chief executives of trusts. Actually, there's a whole load of work that gets done out here, 90% of patient contacts, so I think thank you, that's an important point. Any other key issues, things you'd like to put in there before we
I just
move on?
thought that maybe more comms, so managing, and not just the patient's expectations, but even the staff working in primary care don't always fully understand the roles. Which makes it very difficult to get the message across to patients. So, understanding what a clinical pharmacist does and what an advanced nurse practitioner does, we work in this environment and we have to constantly reinforce it and explain. And it's not until you actually start working with people that it becomes clear
Okay.
what kind of work they can do.
Okay.
There's not a lot of understanding across the board, if that makes sense.
Yeah, and that's a kind of a team leadership role as well, is it's where everybody's clear about what everybody else does and what their contribution to the whole is.
Yeah.
We often bung things in, like clinical pharmacists, and then expect that that's going to work
They will understand it.
without actually thinking about it or how that works. So yeah, good points. Where should we go next? Which table should we go to now? There we go.
We had a discussion in regards to the early on training within undergraduate and junior doctors, whether that's dentists or doctors, and leadership and even business management. Because business management covers a wide range of things. Not everyone needs to be a top leader, but everyone will be leading day to day in their own sense.
Yes.
So whether that's in a dental practice, GP practice or a secondary care setting, I think that medical and dental students should be getting exposure or awareness even to these different things, even doing quality improvement projects. That is kind of part of business management and project plans and stuff, and I think it's at a
Okay.
level we thought it lacked.
So start as early
Earlier on,
as possible.
It doesn't need to be in depth, but it's
Yeah.
awareness and
create the expectation that as important as being able to manipulate your stethoscope or scalpel or whatever it happens to be is the ability to manage the system of care that the patient accesses, because care is not delivered by individuals, it's delivered by systems. So that's, and we get that message across early, becomes a key part of our professional identity and how we do things. Yeah, absolutely agree with you. Sorry.
One of the key points we were discussing around is, and it's a good example I've got would be a healthcare assistant who is looking to train and develop in primary care compared to if they were in a secondary care setting.
Yeah.
And the limitations that you hear it all around is that people are not freed up to develop their skills,
Yes.
progress in their training and education, because either they're not released, or there is no resource for them to actually do it.
Yeah.
And yet, if they were in secondary care, it's not a problem. And it's also to the same extent a little bit with the GPs that even come here is the facility to be freed up to actually take the role further than just what we've always done, which is just fit it in around our clinical work. It just needs to be thrown out.
Yes.
It just needs to be thrown out, and actually there is a role in a specific role for leadership as well as your clinical role. You cannot do both.
Sure.
And the system needs to
Okay.
change to facilitate.
Yeah. Okay. So a number of important points there, isn't it? One is about not having the leadership and management as the 10% that goes on top of the 100%. Actually, it's an integral part. But there's also some important stuff there about creating time for development and working with people's aspirations. Actually, allowing them to do things. We often talk, I think, about being trapped in a low skills equilibrium by not investing. And part of that's because it's primary care is a kind of nation of small shopkeepers, and everybody's worried about, okay, I'll let you go on this master's course, but I know then you're going to be off next year, aren't you? And I'll have spent all that money on you, and you're not going to get any of it back. Working at scale might help us with that, because it'll.
I think the tension there is also around, which is a little bit what I'm hearing a little bit in the group family, is the GP, because there's a lot of pressure that they're feeling, is they're looking for solutions to make their lives easier. And actually, that needs to change. It needs to be actually, we're looking at all of us working together to make all our lives easier. And that's where I have a concern that the GP voice is not necessarily conveying what primary care needs in a good way.
Yes. Okay. Yep. For all sorts of complex reasons. Yeah. Well, some of them not quite so complex, actually. Great. Where should we go next? Other tables? Table. Table. Yes. Sorry. Yes.
I mean, a couple of things that have been sort of mentioned. We've talked about. So we talked about changing the top-down approach, so that we are constantly reacting to sort of government direction,
Yeah.
rather than when I say GPs, I mean the primary care team being the leaders of sort of knowing what's best for our patients, what will work in our environment. And then there isn't a forum. We don't have a cohesive forum whereby GPs can get together or primary care and come have that protected time to have those discussions, and then implement or affect the direction of healthcare travel for our patients. But that's so we just go to work and do the job and go home and moan a bit.
Okay. So it's creating networks and time to do that.
And
yeah.
changing that
Top-down is give us a break, basically.
Allow us to tell you what we feel
Yeah.
will be helpful.
Sure. Yeah. And interesting, more complex. I was reading the other day a critique of the whole kind of leadership thing. It's just a way of controlling people. Telling them they're going to lead, and actually what you're really saying is actually I want you to implement what NHS England wants.
Yeah, exactly.
And that it's not the same thing. Yeah.
The other thing is about empowering people to influence, rather than them just sitting in their silos having a bit of a moan.
Yes.
To actually help them be able to come out of that and say, actually, this is how it should be, this is how we want it to be.
Yes.
And actually
Build up from.
Leadership having its kind of own voice rather than, say, pretending that we're going to get 5,000 extra GPs or pretending that 672 is somehow a good idea.
Yeah.
It's actually having the voice to influence that from the start
Yes.
rather than have to
Yeah.
battle against it.
So the need to feel engaged in developing the solutions. Yeah, yeah. Great. Okay, thank you. I'm conscious of time. I must stop in a second. Sorry, I realise that you're from a slightly different professional background to some of the others around the table.
Might be a bit controversial.
I'm sure. I'm sure it will be.
Perhaps,
I'd already picked that up.
all of us in senior roles within state healthcare could perhaps do with a bit of a reality check, in that we're not special. That there are other private professionals of a similar level, FDs, MDs of other companies, who work very hard, who are for the similar remuneration package would be expected to finish their job. They are often working 10, 11 at night. They work weekends as well. It's not a sort of I accept we're not 9 to 5 here, but it's not a scheduled time. And the fact that one of the things I think that irks a lot of people is that they feel put upon to do work outside of their scheduled working hours. But we're not special, we're not unusual in being, professionals who have to do that. And actually a way of managing that expectation might help people rationalise that actually what we have to work within is something that, is common to a lot of professionals outside of healthcare
Sure.
as well as ourselves.
Yeah.
But that's not.
No?
probably
And it doesn't mean it's a healthy way of living.
It doesn't mean it's a healthy way of living, but it is something that we're not special.
Okay, we're not special.
Just
Okay.
contracted for the hours we do. We're professionals at
Yeah,
a level
yeah.
where we have to work outside.
Yeah, but we might find that attitude changing actually with generations and people wanting something different out of life. Actually, it's not all about nose to the grindstone necessarily. It's about sacrificing some of the kind of the hygiene stuff and the money maybe for a kind of better quality of life. So, and I think that this all kind of feeds into that, making the NHS a better place to work. I think there is a key difference if you do work in healthcare. There is that kind of emotional labour aspect to it that you don't necessarily get if you're a finance director of a company that sells kind of knickers. It's
I disagree, actually. I think as a finance director of a company where if you don't make a go of your business, you are going to put 200 people out of work and put 200 people on poverty line. I think there is also an emotional engagement from those people as well.
I'm not saying it's yes. I'm not saying it's devoid, but it's let's anything else from that table? No.
I'll dive in. We had a discussion primarily about dentistry because it all revolves around dentistry, obviously.
Yes.
As everybody by now has worked out.
Yeah. I'd also pick that up actually.
Thanks. We likened it leadership. So in terms in primary care, is about leadership and a team and using a wider skill mix, has been referenced elsewhere as well this afternoon. And what is developing currently in dentistry terms is that they're actually setting programs at undergraduate level where the various members of the skill mix are learning side by side in the same lectures at the same time. And that there are certainly areas, universities, etc., who are now taking on these programs and then putting the people out into primary care. So they're doing some of their undergraduate learning in primary care, so that people are learning to work together, because there still seems to be a lot of cross boundaries and not an ability to work with one another, just because you don't understand what one another does as much as anything else. So maybe learning elements, and we're still not clear how that's going to work out, but trying to facilitate it so that it will work in the best way it possibly can do is possibly the way forward. Yeah,
and I think that interprofessional learning with and about each other is really important. I think I'm probably less wedded to the multi-professional learning where you stick everybody in the same room and you talk to them saying it's perhaps not quite. And they're different, I think, and they have different kind of benefits. And certainly at the academy, all of our programs, wherever possible, try to maximise that interprofessional learning, because you get, if leadership's about anything, it's about being able to see things from other people's perspectives, really, to understand where other people are coming from, in order that you can kind of work with them and engage them and influence them. So really important that's there. That's really helpful. I've taken. If you've got anything else you'd like to tell me, grab me later. I've eaten into your time, and I'm conscious that you've got to do some presentations. So thank you very much, and that's been great. And yeah, best of luck with your projects. Thank you.